you. Thank you. Thank you.
Thank you, ma'am. I thank the speakers and the chairpersons for a super good educative session. Let's move on to the next and the last session of this Trendo 2020 PCOS update a session. So this session will be chaired by Dr. Jayaprakash Sahu, Additional Professor, Department of Endocrinology, Chipmar, Puducherry. He is the professor with MMS Ahuja Award for the Best DM Student in Endocrinology at 39th AAMS New Delhi. ESI AV Gandhi Award was given to him for the best conclusion for student dissertation. He had multiple publications. Welcome, sir. I invite Dr. Sitesh Ghosh, Professor and HOD of Obstetrics and Gynecology, Mahatma Gandhi Medical College, Puducherry. He also has multiple publications. I request the chairpersons to take over the meeting and to invite the speakers.
Thank you. It's my pleasure to introduce our August speaker, Professor Jenner Tanwe, who is at present professor of clinical medicine and endocrinology in Institute of Women's Health, University College of London. He is a member of several international guideline committees with contribution to reference documentation on PCOS, and he has publications, authors of Handbook of PCOS, Year Medical Handbook, and he has more than 250 publications in PCOS and reproductive endocrinology in high impact journal. And his area of research is PCOS, reproductive and endocrinology. As all of us knows that since 1935, there are a lot of development about the PCOS, especially the management part, right? The pathogenesis, still the pathogenesis, we are discovering new things. Hope our speaker will enlighten all these things. With this, I hand over my session to our speakers.
Hi there. Good morning, everyone. Is that coming through?
Yeah.
Good. Well, I'm speaking from a very dark morning in London where it's just above freezing and raining. So if you could please exchange some of your warmth and perhaps some of the lunch you're about to have through here to London, I would appreciate it. Let me bring up the slides. We're going to talk about polycystic ovary syndrome. And I'll do the slides from this end. Is that coming through?
Yes.
Okay. Well, I'm coming at polycystic ovary syndrome as a reproductive endocrinologist. So as a physician, but of course it is a multifaceted condition. Your fertility people will see the anovulation. Your diabetes clinic, you'll see the older version because there's the overlap with type 2 diabetes. And then in your endocrine clinic, you'll see the hyperandrogenism, particularly often in young women. So there's a lot to it. We're all seeing different aspects. We've run a PCO clinic at University College for many years now, and we've tried to integrate all of that. So we run an ovulation induction service and a metabolic service. And I thought I'd just give you a summary of what our experience is with that. No conflicts of interest. Of course, nearly everything we use as treatment in PCO is borrowed drugs. They're generic drugs that have been reprogrammed or repositioned to work in PCO. So it is, although there are new drugs developments coming up, there's very few that I'm going to mention here. You'll all be familiar with the Rotterdam criteria for the diagnosis. And this is super easy. You just have to have 2 of 3 parameters. And for your barn door case, with hyperandrogenism, hirsutism, oligomenorrhea, you don't even need the ultrasound because you've already got the diagnosis. Now, the difficulty with this diagnostic criteria is that it is all-encompassing. It's intended to be very broad. And by being very broad, it captures some related conditions or borderline conditions. And of course, this is true for all of endocrinology. For every barn door condition like Cushing's, you've got a subclinical version where the diagnosis is much more difficult. And so it is true for PCO. And that's what I really wanted to focus on is what's skirting around the edge of PCO that we need to be thinking about when you don't have just the barn door case. And in leading up to the spectrum of clinical presentation, there's one fundamental point that I think everybody will be familiar with. It's been known for a number of years, and it depends on your ultrasound clinic. But 20% of all women will have the polycystic ovary morphology. So when you think back to those criteria, they are pretty non-specific. And it becomes particularly important when polycystic ovaries is the mainstay of your diagnosis. Because if you have polycystic ovaries and some other cause of amenorrhea, you've mistakenly made the diagnosis. So you have to be a bit cautious about the diagnostic criteria, which is why many societies have tried to refine the diagnostic process to add in a biochemical qualification. To my mind, I don't think anything has stood the test of time. We still have to use our clinical expertise in interpreting this, but it's important not to be too rigid with the diagnostic criteria. So now I'm just going to demonstrate how this is useful as diagnostic criteria and also how we can be misled by them. So there's a cartoon representing the whole of polycystic ovary syndrome with your 3 criteria. Now we can do a think experiment. What if you just have 2 of them? Let's say you've just got hyperandrogenism and polycystic ovaries. What should I be thinking about that makes this case not polycystic ovary syndrome? Well, there are several overlaps, and I've just put in some common ones here. Idiopathic hirsutism, when I trained many years ago, was when all the blood tests were normal. But of course, all of the blood results, testosterone, LH, can be normal in about half of people with PCOS. So where you slot people with hirsutism, are they PCO, are they idiopathic, is going to be dependent on your lab service. Now we're going to come to the point that are these distinctions all essential, and possibly not, but that's the one that commonly overlaps. Acne is a problem we'll see, particularly in adolescence, because a lot of teenagers have acne. And what if you have acne as a teenager and PCO ultrasound? Do you then have polycystic ovary syndrome? The one that I think troubles us a lot as endocrinologists is non-classical CAH, because the two look very similar. And I'll touch upon that in some of the biochemistry slides as to what we're going to do about how intensively do we screen our clinics for non-classical CAH. Androgenetic alopecia, diffuse hair loss is such a common condition. And in many areas, it's much more related to iron deficiency than it is to androgen excess. So it's certainly there, and often it's the only late feature, the only feature in late. You can still use anti-androgens, but don't forget that there's a differential diagnosis for alopecia, that, and you need to put iron at the top of that list and get the ferritin right up. So this is the androgenic phenotype, and I'll just dip into it with a couple of slides. First is the simple endocrinology as a reminder of what we're doing with androgen production from the ovary. So I've outlined there in yellow the theca cells of a follicle. Inside are the granulosa cells in blue, and the theca cells are producing androgens. The granulosa cells are converting to estradiol. The first one, the LH, is mainly driving the theca cell testosterone production. FSH is driving the aromatizations to estradiol. So with that basic endocrinology, you can add in the other components of PCO, of which insulin is hugely important. Now, insulin is really interesting. On all of the in vitro and in vivo experiments of the ovary, insulin acts as a cogonadotrophin. So for every unit of LH driving androgen production, insulin can amplify that. And that's the reason why as people gain weight, they become insulin resistant, their insulin rises. But peculiarly, your ovary remains sensitive. So your insulin resistance is in your muscle and your liver, leading off to type 2 diabetes, but your ovary is seeing that insulin level. And that is that explanation for the weight-related increase in features. And of course, it does allow you a treatment plan because everybody will be familiar with the lifestyle measures and metformin that lowers insulin. So when you think of your treatment, you can suppress the primary drive to androgen production. And the oral contraceptive pill is the most common way of doing that. So there are other ways, almost never used. Glucocorticoids tend to make the insulin resistance worse. GnRH analogs rarely used because they're such heavyweight treatment. And so the pill will be the main basis for suppressing LH drive to testosterone production. Insulin, as we've measured, as I've mentioned, exercise, diet has to be the forefront. Metformin absolutely there and still remains as an important mode of treatment. And actually almost any of the new diabetes drugs, you'll find there are early small series coming out that show that it doesn't matter how you lower insulin, because the ovary is remaining sensitive to it, it will pick it up. So all of the insulin lowering drugs work. And then the periphery is the conversion of, the escape of testosterone into the circulation. And then to complete the sort of clinical picture for hirsutism, you can use your anti-androgen, whatever is available in your country. Spironolactone is personally my favorite. We don't use much cyproterone acetate because it tends to exacerbate the insulin resistance. But they're both effective. So to put that in a treatment plan, which is generalized from all of the reviews in this subject, I think the main treatment that everybody agrees on is to think of your group as to whether you're obese or non-obese. The obese, you really can't start with the oral contraceptive pill because of the higher risk of thrombosis. So diet and exercise is always the mainstay of treatment. And it's good luck to you, everybody out there, as to how you can make the diet and exercise work in people who are fairly rigid with their diet. But we're all up against that in our PCO clinics and in our type 2 diabetes clinic. The approach is the same. So for the overweight, metformin and spironolactone would be my popular choice because they don't exacerbate the risk of thrombosis, and metabolically spironolactone inert and metformin beneficial. If they're still overweight on down that column, you're really adding in more drugs is not going to be effective because you just can't overcome that drive of insulin to the ovary. So you're really looking to for other weight loss methods. There isn't a clear guideline here because you have to individualize it to your population. Down the lean side, mostly we are choosing a low-risk oral contraceptive. So your contraceptives can be categorized into whether they're high thrombotic risk or low thrombotic risk. Unfortunately, the anti-androgen ones, Yasmin and Dianet, are high thrombotic risk. So I tend to start with a generic, probably second or third generation progestogen, and then add in a spironolactone. I personally find that a much more flexible approach because you can titrate your anti-androgen and you can titrate your pill to 20 micrograms or 30 micrograms, but you're not having to use a fixed dose as you would find in Yasmin or Dianet. Plus, you're free to, you've come in with a lower thrombotic risk. Then I tend to see people every 6 months. If you're not improved, you can add in another anti-androgen. It would make sense to use an anti-androgen from a different category, like a 5-alpha reductase inhibitor. Then there are the topical methods of addressing hirsutism, which actually, now I look at it, probably ought to be bumped up a bit because for many people, they would, if they just have facial hirsutism, they would escape the need for systemic treatment. If you're lucky enough to get to a place where the individual is confident and reasonably happy with the compromise that treatment gives them, then the idea is to cut back in dose and find the minimum that holds it. There are some who will have to be on some maintenance treatment, perhaps a low-dose pill or spironolactone alone, more or less indefinitely. I touched upon idiopathic hirsutism. I don't mean to take in this small print, but I just grabbed this as a screen grab from a general advice sheet on hirsutism. And I just wanted to make the point that all of the treatments for idiopathic hirsutism, that is no endocrinopathy, normal ovaries, they're the same. So your eflornithine or Vanicas at the top, you've got the oral contraceptive pill, and then you've got the anti-androgen spironolactone finasteride cyproterone at the bottom. So when you look at this, you think, well, actually, I don't have to make a distinction. There's no reason why one group gets full treatment and another group doesn't. You can address the hirsutism side completely on clinical grounds without the need for extensive investigation once you've ruled out the aggressive conditions. This is from my take on the issue about the overlap with non-classical CAH, which still causes a point of confusion. Many of you will know this nomogram. It dates from the 1960s. It's when Maria New in New York classified all their patients with CAH according to their baseline 17-OHP on the x-axis and their stimulated 17-OHP on the y-axis. And they said that they could make complete distinction between classical CAH, non-classical CAH, and normal. Now, the difficulty comes, and the bit that's sort of hidden in the literature, is that PCO spans the bottom end of that. So there's an overlap of 17-OHP coming from the ovary, in this instance, not the adrenal, into the non-classical CAH route. And we don't really have a good diagnostic cut point. There are some around, a baseline 17-OHP of around 7 to give you a reasonable cut point, but it is never exclusive. But of course, the same thing applies to idiopathic hirsutism. For a mild case of hirsutism, you're not going to treat with steroids unless desperate. So the same approach can be used for using the pill and anti-androgen. So I personally don't go out of my way to screen for low-level non-classic CAH. The time you break that rule is in the fertility clinic. Then people with non-classical CAH that's when they need steroids. But outside of that, so I recheck 17-OHPs only in the fertility clinic. So that's a super quick skirt round the androgenic phenotype and the two big overlap syndromes, which is non-classic CAH and idiopathic hirsutism. I'm now going to put that to one side. And we're going to choose two other diagnostic criteria, which is just the oligomenorrhea and amenorrhea and polycystic ovaries. So these are women who have no other androgenic symptom. And non-classic CAH can do that. Usually they have an androgenic symptom, but sometimes you're caught out. I've kept that up there. And then you've got a series of situations where people would mimic that PCO diagnosis. Hypothalamic amenorrhea is really common in Western countries, particularly in North America and Europe. And this is, you can think of this as a mild form of the athlete triad of low LH, low estrogen. But the milder forms are really hard to distinguish because once again, the endocrinology can be normal. And often you can only base it on history. 20% will have polycystic ovaries on ultrasounds, so would qualify. And I guess if you were going to add a fourth criteria for PCO, it would be amenorrhea that's not otherwise explained. You really have to have your radar out for that. Raised prolactin is a problem because 10% of all women with PCO have a mildly raised prolactin, usually 2 or 3-fold raised above your upper limit of normal. And those can be really difficult to distinguish. Where's the primary drive here? Is this hyperprolactinemia with incidental polycystic ovaries, or is it polycystic ovary syndrome with raised prolactin? Once again, in the mild areas, it doesn't make much difference. I think if it's in terms of fertility, one would usually start with a dopamine agonist to see, will that bring me a regular cycle that I don't need to use ovulation induction for? And for many of those cases, the prolactin just comes down. So I would only treat the prolactin directly in very specific cases where anovulation is clear and you want to give a trial of the dopamine agonist. Otherwise, the bloods look very similar. Raised prolactin tends to be low estrogen, and PCO are estrogen replete. But when you get to the crossover, it's hard to distinguish. I'm going to touch upon the teenagers or what happens after menarche in a second. So this is the reproductive phenotype. And you can have the reproductive phenotype completely separate to the androgenic phenotype, although of course, some people will have both. The main reproductive hormone we measure is AMH. It caused great excitement when it came out. Here's a paper in 2003 showing in the shaded boxes the controls and in the clear boxes the PCOs. And so PCO generally has about twofold increase in AMH, and they're coming from all those small antral follicles that are the PCO morphology. The difficulty, like all the other endocrine parameters, is there isn't a cut point that really helps you distinguish. If you get a raised AMH, that's great, but many women would have a normal AMH. And so the overlap is such that it doesn't make it a hugely useful cut point. I'm going to move past this because there is also a problem with AMH that I think is under-realized. As endocrinologists, we know that there's a lot of noise in the assays, and we know that you can't put too much evidence on one reading because all of these hormones vary and the laboratory is variable. Well, with AMH, the scatter here, this is a data mining exercise from Glasgow, where they've collected a load of AMH measurements from the early days of its use. And you'll see AMH follows an interesting pattern. It reaches a peak at around mid-20s. And it's only after 35 that the fertility people use this as a more or less linear prediction of ovarian reserve. But look at the scatter. These are normal people down here. And of course, they're down at the 10th centile. There are 10% of people down there. So I always find I'm in conflict with some of my fertility colleagues, where the IVF clinics will put a lot of weight on AMH. But as endocrinologists, we know it's just another hormone with a lot of scatter in it. And AMH is not immune to that. So be wary about AMH. It's a noisy hormone. Then there's adolescence. And here I'm just going to touch on something you'll be familiar with in your clinic if you see teenagers. The difficulty with adolescence, one of the many difficulties of adolescence, is that acne is common, a feature of androgen excess. Irregular periods are common, as I'll show you in a second. And also, as you go through puberty, the ultrasound can look very similar to polycystic ovaries. There's a condition that was originally called multicystic ovaries, which is that puberty ovary that is waking up before the pulsatility of LH and FSH has become regular. And you need a very specialist ultrasonographer to tell the difference between the two. Because of this noise in adolescence, I would counsel against making the diagnosis really concrete in a teenager. So you can still treat the symptoms, but I think it's helpful not to leap in with a diagnosis. Here's the normal variation in menstrual cycle, which we're all familiar with. That after menarche, the periods take a while to become regular. But here's an old paper from the 1960s where they've actually measured that. And so the x-axis is years post-menarche, 1, 2, 3, 4, up to 7 years. But you'll see how long it takes, in fact, when you follow a population to get a 40-day cycle length. You're out at about 5 or 6 years before it's reliable. So that's taking on this piece of information. If they present with oligomenorrhea in adolescence, I would usually try and postpone making a clear diagnosis until the age of 18 or even 20. The other reason why adolescents have a particular problem from the endocrine point of view is that adolescence is a time of hyperinsulinemia. A rather forgotten about feature of puberty is at the end of the growth spurt, you're quite insulin resistant in your muscle and liver, but then that recovers. And but of course the ovary is the sensitive organ that's seeing that. So this is fasting insulin measurements through puberty, reaching a peak at around the age of 15. And of course that matches our clinical experience because we see quite a lot of post-menarcheal teenagers at around that age with androgen excess symptoms. And this is one pointer to make us think that metformin is really quite a good treatment in this group. particularly if you're cautious about starting an oral contraceptive pill in a young girl. There is some evidence to say that metformin, even in lean teenagers, is a very effective treatment. And this is the reason. Going to skip past that. So just to complete the reproductive phenotype, there are really good guidelines for the management of polycystic ovary syndrome, headed by Helen Teed in Monash in Australia, in Melbourne. And I'm just going to take the punchline out of the fertility section here, but well worth reading. It's the international guidelines and the best there is, to my mind. Lifestyle, as I said, is always the first line treatment, almost for every case you see, except the most lean women with PCO. Letrozole is interesting for those doing ovulation induction. Letrozole came out 50% better than clomiphene citrate and has taken over as our first line treatment in most clinics. Has the same effect of lowering estrogen, raising gonadotrophins and driving through ovulation. And metformin came out as beneficial as an adjuvant treatment. Metformin has swung over the years as to whether it's effective or not effective, but they summed all the data up and said that actually it is an effective adjuvant. So have a low threshold for using metformin in the work up to fertility for an ovulation. Okay, well, we're going to put that one to one side. And I've just got one other phenotype to think about. And this is if you add an imaginary fourth criterion, and I'm going to put in overweight. It's so confusing now because of the obesity epidemic. We think overweight is a definite criteria for PCO, but let's not forget that there are lean women who have the clear features. But overweight, because of the hyperinsulinemia, is such a confounder now, and it drives our management. We've said that the late adolescence is a time of hyperinsulinemia, so I've left the teenagers on there. Metabolic syndrome we'll look at. Simple obesity is a problem because even a normal ovary where you'll have some androgenic symptoms, and it can be very difficult to make a distinction between simple obesity and mild polycystic ovary syndrome. Type 2 diabetes, I think everybody in the room is expert at that. And I'm going to just touch upon the fact that it's the same gene pool. So people seeing hyperandrogenic young women need to prepare them for their journey through life where they have a higher risk, not only of gestational diabetes, but also of type 2 diabetes. And that's why lifestyle is right up there. So this is the metabolic phenotype. This is acanthosis nigricans of insulin resistance. And in a way, you can see the skin is sensitive to insulin too, just like the ovary is. So if you sort of put the ovary in where you're seeing the acanthosis, that's what the ovary is doing in response to insulin. Now, the vast majority of women with PCO will fulfill the criteria for metabolic syndrome if you're measuring either their waist circumference or their fasting hyperglycemia, and not a majority, but certainly up the overweight group, you're getting a lot. It's interesting to follow this through because you would have thought that would give them a high risk of cardiovascular disease. And there is a conundrum that has been in the world of PCO for many years. I've said that you can see the risk that you'd expect of gestational diabetes and type 2 diabetes. But the cardiovascular risk has been really hard to ascertain. One of the problems is you need such a long follow-up to get that cardiovascular events clocked up. But even the studies that have gone out 30 years are uncertain whether they're seeing cardiovascular excess. Management for metabolic syndrome is the same as everywhere. It's lifestyle, and don't completely rely on a prescription of metformin because all the diabetes prevention studies would say lifestyle beats it. Those of you prescribing in this field will be aware of myo-inositol is getting a huge hype on the internet. It has an effect of an insulin sensitizing effect that's similar to metformin in lowering insulin. It is hugely marketed, and it's marketed in many countries as a sort of supplement rather than a drug. And I think it's because it's so hard to prove it's beneficial. There are small randomized controlled trials, but there's a strong pharma bias in them. So that it's very hard to get independent clear representation of benefit from myo-inositol. So I'll put my cards on the table to say I'm a myo-inositol cynic, or inositol in any form, compared to metformin where we have good data. You will be quoted randomized controlled trials, but look at them carefully. I think that we haven't seen a really clear benefit there, and the guidelines don't favor it. I have one little point to raise, because it's relevant to the population in India, and this was a collaboration project I did with Sachin Kulkarni in Kolhapur, South Maharashtra, and it gives you an idea of that insulin effect. Here is, he collected a large group of women with PCO. We cut it down to about 700 in the end. But of course, in South Maharashtra, there's a wide variety of diet, from the rural women who just have one carbohydrate, to those who are having a more complex carbohydrate, to then those that are non-vegetarian, and then those that have moved into the urban centers and are eating a high degree of refined carbohydrate. So this group was cut up into which of those diet groups you were in. And I'll take you through this slide. I cut it out of the paper, so it's not easy to read, but I'll take you through it. BMI is in the top left. Of course, as you have a poor diet, your BMI goes up. Your Ferriman-Gold score goes up. So that's, as I've said before, that's the insulin driving your ovary to make more testosterone. And on the top right, you're seeing the insulin. But the interesting thing from this study was the bottom right, where you're seeing a rise in AMH. So this is the PCO phenotype. In a way, that ovarian hypertrophy I was extrapolating to the skin is being active. You're pushing more follicles with that gonadotrophin drive of insulin. Now, we think that that's reversible. We know in many situations it is, but it just shows you the degree to which your diet and lifestyle is driving this condition. I have pondered on this quite a lot, because when I give the lecture in the UK and in North America, it's quite evident with depending on where you are in your country's urbanization, it varies. And in a very simplified form, I've thought that in the US particularly, Mexico particularly, UK quite a lot, high sugar intake is a feature of a low socioeconomic group. And so that's where we're seeing our gestational diabetes and our type 2 diabetes. It struck me, and I don't know whether your practices reflect this, or if you have an urban practice, it's not obvious, that I think in many countries, it appears to be the opposite. So the sugar is quite an expensive commodity as a refined food group. And in rural people, there will have easy access to cheap, fresh fruit and vegetables. And then it becomes, as you urbanize, you become more insulin resistant. It's just an interesting difference. And of course, that will change with time. That green line is going to start morphing over to the red line as the population changes. Okay, I'm going to conclude there. One of the things that have fascinated me is that point that despite the adverse cardiovascular risk markers, we haven't seen cardiovascular excess events, to the point where people are questioning, could there be something about PCO that actually protects you from cardiovascular disease? Unproven point, but rather fascinating. Here, just in conclusion, is a reminder that this is a big condition. This is 10% of all women. And I suppose the message I want to take home is that you can morph from your androgen to your reproductive, and you head towards the metabolic. But you need to be aware of the whole components, and where you're overlapping with other conditions. So it was to give you that multiple phenotype form of it, depending on your practice. And I'll leave you with that summary. Happy to take questions.